So in talking about this with my two practices, I found a new word to lose, and it's called work-in. It's used as a noun to apply to a patient. So if you're my medical home and I wake up in the morning and I'm sick, and I call you because I want to come in because I have gunk coming out of my eye, I'm a work-in. That's a new addition to my words to lose. I think you really want to think of the patients that you need to see that day are part of your work. You're not a work-in. You're not doing them a favor by seeing them. That's part of your work. Okay, so what do we need to do to document this for NCQA? Well, first of all, I would get started soon. One thing you need to remember is this element requires a written process. Anything that requires a written process for NCQA, the process needs to be dated and needs to have been in place at least 3 months before you apply to NCQA. So you want to get these processes in place and dated this summer at the latest. I'm hoping you're not going to push it to September and push your application to NCQA to the end of December. I'd like to see it happen a little sooner than that. So here's an example from, oh, and I'm sorry, for people who are not on the webinar, I'm on slide 9. This is an extracted policy from the template that we will work with you on. So remember I said that the element requires 3 things for each of the factors. It requires a standard, it requires a method, a procedure for how we do it, and it requires monitoring. So these are the kinds of things you need to get into your written policies. The way we've developed them, we're not making your decisions for you. This is just language that you can use when you get together with your team. If you don't already have these kinds of policies, to sort of tell you what you need to address in your policy. So for instance, this is a very simple statement of a practice's standard. We schedule patients for appointments the same day they call, if they request the same day appointment or if staff determines that the patient needs a same day appointment, blank % of the time. I would encourage you to really think about what that percentage is, to actually monitor and see how you're doing now. And I would encourage you to make it a pretty high percentage. Because if patients feel that they need to be seen or you feel they need to be seen, you want to manage your schedule so that you're able to see them. And then the second part is this is our process, this is how we do it. So we leave X number of appointments open in each clinician's schedule, including X in the morning and X in the afternoon. You might say, instead of that, you might say, you leave one clinician completely open in the morning and another clinician completely open in the afternoon. There are a lot of ways to do this. There's also an element in this standard which asks you to monitor what % of patient appointments are with their chosen preferred primary care clinician. Those 2 elements don't have to overlap. So it's very reasonable to say that, for instance, our process for providing acute care appointments is that they see the doctor or the nurse practitioner who's on duty for acute care appointments. If you have a more sophisticated system, if you have appointments and you are able to get people to their chosen practitioner the same day, that's great. You're moving further towards being a patient-centered medical home. So, and then whenever you come in our templates, you'll see these little brackets. So monitoring once every X months, you decide how often you want to do this. And then here's 2 brackets. Manually, you can monitor this manually, which frankly for this one, most people do it manually, or by querying the EHR or appointment system. You can see there's 2 sets of brackets there, so you can choose which way you're doing that. We monitor whether we're meeting our standards. And as I said, we'll have a spreadsheet you can use to do manual monitoring for all of 1A and 1B. Okay, so I added work in to my words to lose and words to use. We've already talked about compliant and non-compliant and changing that to engaged, activated, taking ownership. Now I'd like you to lose work in, especially since it's a noun, it refers to a patient. The words you want to use are same-day appointments, open access, rapid access, advanced access, something that indicates this is part of what we do, and it's based on our patients' needs as determined by both them and us. So I'm going to stop there, and David, would you open up the line so we can see if there are any questions?
That's pretty self-explanatory, though. Linda, the lines are open. It's kind of like you either do it or you don't. If it's a requirement.
David, it just said unmuted again.
Linda, the lines should all be open.
Okay. Okay, so I'm assuming we have no questions then, so let's go on to the second half. And one thing I should have said at the beginning is we're going to use this webinar to get you started with access and with setting up for QI. And then the webinar in April we're going to use to collect your experience so far with how you're doing, the questions you have, the kinds of QI projects you are thinking about beginning or you're already doing. Okay, David, we can mute the lines again. I think we better do that. Okay, looking at whoops. It said muted and then unmuted.
Yep, you're unmuted, Linda.
Okay, I'm unmuted. Okay, good. Okay, so slide 11 here is quality improvement. And you remember going back to that slide 3 showed that we're going to start now, while it's still March, start on access standards and QI preparation. So let's talk in general terms about QI, and then Peggy's going to spend some time on the patient surveying part of QI. Let's see if we can get it, the slideshow to work. Okay. So all NCQA programs require the organizations applying to measure what they do, think about how to do it better, try new processes to do it better, and then remeasure. It's a very important component of all NCQA programs, and it's also an important component of the patient-centered medical home. It's one of the principles that was adopted by the medical societies, the national medical societies, that put out the principles for the patient-centered medical home. So I apologize that we're going to have to look at our slides this way because for some reason they are not advancing. Okay. So what do you need to do? Let's see if I can make it a little bigger. I hope everybody can see this. All right, I'm not going to worry about it. So for quality improvement, as I said when I asked this on March 1st, 3 of the 10 of you said that your organizations have ongoing QI processes. That's great. Just keep it going. Just take a look at the standards. It's standard 6, elements A and B, and see if you are producing the measures that are required by those standards. Figure out what you want to use to show to NCQA. For the other 7 who are not there yet with a quality improvement process, you want to start with 6A. We're going to talk about 6A and 6B, neither of which is a must-pass standard. But 6C, which says you actually use the results of 6A and 6B to do improvement, 6C is a must-pass element. So taking a look at 6A, it looks for you to show actual measures of clinical performance and utilization performance. And that utilization is usually pretty hard for practices to do unless they have information from health plans or from their related hospitals. So, but for clinical measures of process and outcome for chronic or acute care and for preventive care, I recommend, now that we have meaningful use, that you take a look at your EHR's capability to produce meaningful use measures. To the extent that it does, this is going to be really easy for you. At least measuring is going to be easy because there's a long list of measures, over 40 I believe, that are in the meaningful use system either as core measures or menu measures that an EHR that's certified for meaningful use needs to be able to produce.